All right, so if you're a medical trainee, listen up. You're definitely going to see patients with bile duct stones. It's a super common problem, but let's be honest, figuring out the right steps can feel like a puzzle. In this explainer, we're going to crack open the latest ASGE guidelines and give you a clearer, evidence-based roadmap for your next rotation. So why is this so important to get right? Well, let's start with a number, $2.6 billion. That's the whopping annual cost of acute pancreatitis right here in the US. And what's the number one cause? You guessed it, bile duct stones. So yeah, mastering this has huge implications, both for our patients and the healthcare system. Now, the official term is choledocholithiasis. It's a mouthful, right? But all it really means is that a gallstone, which you know forms in the gallbladder, has decided to go on a little trip and got stuck in the common bile duct. And this isn't some rare, exotic thing. It happens in up to 1 out of every 5 patients who are already having symptoms from their gallstones. Okay, here's our game plan. We'll kick things off with the basics, then we're going to follow the patient's journey step by step. We'll talk about that crucial first decision, how to diagnose. Then we'll navigate the tricky waters of pancreatitis, tackle those really tough stones, and wrap up by making sure this problem doesn't come back to bite. So let's jump right in at that first major fork in the road. Your patient comes in, you suspect a bile duct stone. What do you do next? This is one of the most important calls you'll make. It's all about choosing the right path for the right patient. How do you tell the difference between the patients who almost certainly have a stone, those who might have one, and those who probably don't? Because, doing an invasive procedure like an ERCP on someone who doesn't even have a stone, that's not just a waste of time, it comes with real risks. Thankfully, the guidelines give us this amazing tool to stratify patients into really clear risk categories. So for your high-risk folks, we're talking a stone you can actually see on an ultrasound, someone with active cholangitis, or a bilirubin over 4 with a dilated duct. Those patients can go straight to a therapeutic ERCP. But pretty much everyone else is going to fall into that intermediate or low-risk bucket. And for that big group of people in the middle, the intermediate risk patients, the key is to pump the brakes. We don't jump the gun and go straight to an invasive scope. The goal here is simple. First, we confirm if a stone is actually there with a less invasive test. And we've got 2 main options for that: endoscopic ultrasound, or EUS, and MRCP. Honestly, they're both excellent at confirming stones, with specificities over 90%. That means if the test is positive, you can pretty much take that to the bank. Where they're a little different is sensitivity. EUS is just a bit better at making sure you don't miss a stone. But really, the guidelines say the choice comes down to what you're good at locally, cost, and what's available. Okay, now let's switch gears and talk about our next scenario, gallstone pancreatitis. This is where the guidelines really push back against that we have to do something right now instinct that we all have. For your typical patient with gallstone pancreatitis, and this is the absolute key, without signs of infection like cholangitis or a persistent blockage, the evidence tells us to wait. The guideline literally recommends against rushing in to do an ERCP within 48 hours. It's just not the answer. And you might be asking, why? Why wait? Well, when researchers pooled all the data from randomized trials, they found that jumping in with an early ERCP just didn't help. It didn't lower mortality, and it didn't reduce the rate of local or systemic complications. It's an intervention that adds risk without a clear benefit for this specific group. But, and this is a huge but, there is a critical exception. If your patient with gallstone pancreatitis also has cholangitis, meaning a nasty biliary infection, then the whole game changes. In that case, an urgent ERCP to drain that infected system is absolutely the right call, and it needs to be done. Okay, so we've confirmed there's a stone, we've decided it's the right time to go in. Now for the main event, actually getting that stone out, especially when you're up against one that's big or just plain difficult. So let's say you're facing a big stone. Usually that means anything bigger than 10 millimeters. Is a standard sphincterotomy, that little cut at the opening of the bile duct, going to be enough to get it out? Let's see what the evidence says. Now, this is a forest plot. Don't let it intimidate you. Each of those horizontal lines is a study, and the big diamond at the bottom pools all the results. All you need to know is that since that diamond is way over to the right of the center line, it means the combination therapy is way, way better than doing the sphincterotomy alone. So what's the bottom line? Adding a large balloon dilation on top of your sphincterotomy makes you 2.8 times more likely to successfully clear that big stone. That's not a small difference. That's a total game changer. and it's a key technique to have in your toolbox. But what if the stone isn't just big? It's really, really difficult. It's impacted or has a weird shape. Do we need to pull out the big guns like cholangioscopy-guided lasers, or can our conventional methods still win the day? Well, at first glance, the success rates for the fancy intraductal therapies and the conventional methods look pretty much the same. Both are around 92%. But the secret is in the details. Look at the conventional therapy group. If you don't use papillary dilation, the success rate is only 81%, but when you do use it, it skyrockets to 95%. So here's the crucial point. The power of that large balloon dilation is so massive that it boosts conventional therapy to be just as effective as the more complicated, more expensive intraductal methods. This means a really powerful tool for difficult stones is probably more accessible than a lot of us think. So we got the stone out, the patient feels better, our job's done, right? Well, not so fast. The final chapter here is all about prevention. How do we make absolutely sure this doesn't happen all over again? So the bile duct is clear. Is the patient's journey over? Not by a long shot. We've treated the complication, the stone that got stuck, but we haven't dealt with the source of the problem, the stone factory itself, the gallbladder. The landmark Poncho trial tells the whole story. If you send a patient home after gallstone pancreatitis and plan to take their gallbladder out later, the risk of coming right back to the hospital with another biliary issue is 17%. But if you do the surgery during that same admission, that risk plummets down to just 5%. So it's really no surprise that the guidelines' final recommendation on this is crystal clear. For patients with mild gallstone pancreatitis, the definitive treatment is to remove the gallbladder during that same hospital stay. Don't wait. So we've covered the whole journey, from diagnosis all the way to prevention. But I want to leave you with one final thought. The guidelines are great for helping us manage difficult stones when we find them, but what's the next frontier? As our imaging and tech get better, how can we get better at predicting which stones are going to be a real headache before we even start the procedure? Now that is the challenge that lies ahead.